Chapter 3, Learning Clinical Skills. Overview. This chapter covers how you can work out what you need to learn. It discusses clinical examination skills and practical skills, how to learn them from books, from simulation and with patients. The clinical learning environment is very different from the classroom environment. We'll give you some tips on how to make the most of your tutors and how to make the most of the time when tutors are not around. Finally, we will cover feedback, how to give effective feedback, how to get effective feedback, and how to learn from the feedback that you are given. Introduction. Clinical skills are what make doctors. Without the ability to take a history and examine the patient, you will not be able to make a diagnosis. Without practical skills such as cardiopulmonary resuscitation, taking blood, inserting drips, you will not be able to conduct further investigations and treatment. Without effective clinical communication skills, you will not be able to explain treatment options to the patient and enable them to understand and to choose the right option for them. You will start to learn these skills at medical school and you'll continue to improve and learn for the rest of your professional life. The next chapter specifically covers clinical communication skills, the evidence base for learning clinical communication skills, how to make the most from learning in simulation and how to improve your clinical communication skills in the clinical environment. There is a recurring theme in both these chapters, and we make no apologies for highlighting it repeatedly. You cannot learn a skill without knowing how to do that skill, without practicing it and practicing it a lot, and without receiving feedback. All three parts are important, but practicing is the part which is most commonly neglected. Compare with any other skill, whether it be playing a violin or playing football. To become an expert, you need thousands of hours of deliberate, reflective practice. Learning skills is different to learning knowledge, but needs just as much commitment to time and effort. To learn a skill, you need to know how to do that skill. You need to practice deliberately, thoughtfully, and endlessly, and you need to receive and act on plenty of appropriate feedback. If you cover these three aspects, you'll be set for life. On first encounter, the clinical learning environment can be a daunting place. It is unstructured, often chaotic, and requires a lot of self-directed learning. If you are seen to be keen and enthusiastic, and if you actively seek out learning opportunities, then people will go out of their way to teach you and provide you with even more learning opportunities. You will feel valued and learn lots more than your peers, and you will be better prepared for being a junior doctor. How do I know what to learn? Finding out the sort of skills that you need to learn at medical school is slightly easier than what knowledge you need to know. However, the same broad principles apply. By graduation, you need to have become a safe and competent new doctor. This means that you need to be very good at the skills that you will use commonly and at the skills that you may need to use less commonly, but in an emergency situation. The next layer down covers the skills that you should be able to do under supervision. You should have seen and done enough of these to feel confident that you can perform these with a senior watching. Finally, there are skills that you need to know about so that you can explain them to a patient. Your medical school may publish lists of what skills you should gain in a number of formats. This will include being buried in course objectives. By the end of this workshop on lung function, you should be able to measure a patient's peak expiratory flow rate or in year objectives by the end of the fourth year. You should be competent at conducting a female genital examination, speculum examination, bimanual vaginal examination, and perform a cervical smear, or in your overall curriculum, which may define the skills required for graduation. Many schools publish some sort of lists in the form of logbooks or portfolios For example, at Barts and the London we published a 5-year reflective checklist of clinical and communication skills which shows how skills build on each other year to year. We also had a year 4 logbook which included clinical skills and a statement in year 5 about skills that might be assessed in the finals. Figure 3.1 different levels of proficiency are required for different skills. Need to do every day or need to do in an emergency. Need to be able to do under supervision. Need to know about to be able to explain to a patient. There are some national publications too. Every few years the General Medical Council updates tomorrow's doctors, which goes some way too. Defining minimum curriculum content. Modernizing Medical Careers has published a curriculum for FY1 and FY2, and other people have had a stab at it too, including the Scottish Doctor Project. Clinical skills textbooks aren't bad either. MacLeod's, Munro, and Campbell. 2000 and Hutchinson's are two popular ones. A look at the chapter titles gives a reasonable indication of the range of skills that you might be expected to be able to do. So which list of skills is right? Unfortunately, you're going to have to make some judgments and build a consensus between these different sources. Forget the published lists for a moment and make your own. What skills will. You need to be a newly graduated doctor. You might spend an hour or more thinking about this. Structure your list in a way that makes some sense to you. Check some of the other lists available listed above and see what you have left out. Keep your list with you, go through it regularly, annotate it and add to it. It will become far more accurate and far more relevant than other people's lists. Perhaps your list could be the first section in your clinical skills folder. Level of competence. We've alluded to this already. Some skills you need to be pretty good at, others you should be able to do with supervision, others you need to know about. There are various different grading scales you can use between ignorant and expert. Clearly your long-term aim is to become an expert, but at medical school you should aim to become good or at least better than good enough in all the core skills. Learning clinical skills. A model for the self-directed learning of clinical skills. Learning clinical skills is very different from learning knowledge. The chances are you are pretty good at learning knowledge with good levels, and GLSC is there are plenty of books on improving your study skills for knowledge, and chapter 2 of this book adds to that large body of information. When it comes to learning clinical skills, though there is very little out there, there are quite a few published papers talking about how the teacher should teach clinical skills, but also plenty of papers telling us that most of the learning of skills that students do is picked up along the way and not formally taught. How best to pick it up along the way is not mentioned. Table 3.1 Benner's model of levels of achievement. Note that these relate to each skill. An expert at taking blood might be a novice at cardiopulmonary resuscitation. Stage 1 Novice. Little or no prior experience of the skill. Tendency to focus on the skill itself rather than multi-use. Pick out what the results mean. Follow fixed rules that can't be adapted. This rule-governed behavior is extremely limited and inflexible. Requires full supervision and support. Stage 2 Advanced. Beginner starts to recognize patterns from prior experience. Starts to use some level of judgment, able to adapt to different situations and contexts. Rules turn into guidelines. Developing dexterity. Stage 3 Competent. Begins to see actions in terms of long-range goals or plans. Conscious and deliberate planning. Able to adapt to and manage complex contexts. Stage 4 Proficient. understands situation as a whole and how one skill fits into complex tasks. Long-term planning, how does this skill and the way it is performed affect the future? Appropriate prioritization, able to make complex judgments based on experience. Stage 5 expert, accurate, intuitive, unconscious performance, deep understanding of how a skill fits into the whole situation. When looking after students who struggled with clinical skills learning, it became apparent to us that there is often a problem with students not knowing how to learn clinical skills. Some students just read the books without ever practicing and then seem surprised when they don't seem to be able to translate knowledge of how to perform a skill from their heads into their hands to actually perform it. Other students practice and practice but never get a good idea of how they should be performing a skill. Their clinical skills are often radically different from the norm and they are unable to justify why they do each step. Finally, some students mimic a video or a demonstration and practice until perfect, but without feedback they become very fluent at doing things wrong. In a recent second-year objective structured clinical examination, a number of students had practiced using an online video resource for abdominal examination. They said the same words as the doctor in the video and made the same movements, but because the camera angle hadn't been perfect, they ended up examining mostly the chest rather than the abdomen. In response to recurrently seeing these problems, we developed a simple model for learning clinical skills. It differs from all the other models in that you, the student, are central to the learning. This is how you will learn as a doctor, and this is how most of your clinical skills learning will occur as an undergraduate. The model describes three simple stages: theory, practice, and feedback. Building a theoretical framework on how to perform a skill. To perform a skill, you first need to know how to perform it. To play tennis, you need to know how to hold the racket, where to stand in the court, how to strike the ball, forehand and backhand. You need to know the rules there. Scoring and 101 other things, otherwise you just stand there lost. Similarly, for a clinical skill, you need to know how to do that skill, what steps there are. To doing it, imagine that you are going to examine a patient's abdomen. You need some knowledge of what you will be doing before you give it a go. Often a clinician will show you their way of performing a skill, and that might act as an initial framework for you on how to do it. They are likely to tell you that their way is the best way, and it is likely that their way is the best way for them, but may not be the best way for you. Have a look in a clinical skills textbook or to look for other accepted ways. Have a look perhaps on the internet and have a look at handouts from clinical skills sessions. They are likely to be similar, but look for the similarities and particularly the differences. Try and summarize the steps to perform a skill on one sheet of A4. Figure 3.2, the Evans-Brown model for learning clinical skills. Clinical skills, knowledge, practice, feedback. It used to really bother me that different consultants had different approaches to the same skill and wanted me to do it their way. It took me ages to realize that over the years I would need to find the way that works for me. Philip, fourth year medical student. An interesting model devised by Martina Michels identifies three different parts to the knowledge required to perform a clinical skill. The first is the sensorimotor aspects, the trick, if you like, the steps that you go through, where you put your hands when most clinical skills instructions, textbooks, and videos cover these aspects well. The second aspect is an understanding of the underlying principles, anatomy, physiology, even basic physics such as the principles of levers that justifies why each step is being taken. This is where those students who just watched the video went badly wrong. They just put their hands here or there because that was what was done in the video. They didn't understand that they were supposed to be feeling for the spleen or the liver, nor did they know where to find those organs. The final and most complex part of the knowledge is about clinical reasoning, making sense of your findings in order to make a diagnosis. Even knowing which examination might be appropriate in which situation. As an example, let's take respiratory examination. You could be taught the steps of how to do it pretty quickly and with some practice and feedback. You might get reasonably slick, but you will not understand testing for chest expansion unless you are aware of respiratory physiology and the anatomy of breathing. Unless you know the anatomy of the posterior chest wall, you will not be aware of the effect that the scapulae have on your percussion and auscultation. If you do not know your surface anatomy, you will not know if you are percussing over liver or lung. And as for clinical reasoning, you need a whole new set of knowledge to help you put together your findings into a diagnosis. There is a difficulty here in deciding at what level to learn a skill. Try and learn too much information in one go and your brain will become overloaded and will forget everything, yet learn just the trick of how to do it, and you might stop thinking and questioning yourself while you examine a patient. If you stop thinking, you will never recognize normal or abnormal. Our recommendation is that for each skill you have 3 sheets of A4. The first sheet contains one side on the right way of performing a skill that you decide on by comparing 2 or 3 different expert sources. The second page should contain about one side of the key basic sciences that you need to support the performance of the skill. The final page, which you might write only after you have started to master the skill, contains the clinical reasoning, perhaps a heading for each major condition with the key features listed, or perhaps a table of key features with their corresponding conditions. This last page is an excellent opportunity for using Cornell notes or tables. Practice studies of expertise in many different disciplines suggests that about 10 hours of reflective, deliberate practice is required to become expert. You can't get away from this. If you want to get good, you need to practice, and practice some more. David Beckham has been playing football since he could walk. The same goes for clinical skills. If you want to be good at taking blood, good at taking a history, good at examining a patient's respiratory system, you not only need to know how to do it, but you need to have done it again and again to transfer that knowledge from your head to your hands. I thought that because I had taken blood pressure once, I knew how to do it. When it came to the exam, I was all over the place. I think it takes quite a bit of practice to be able to do things under pressure. AppMed, first year medical student. For most skills, you would start by practicing in simulation, perhaps in the skills labs, perhaps on your friends and family. An example of this is that there are 2 main pulses in the feet that you need to be able to feel. If you can confidently say that they are absent, then that gives a good indication that there is peripheral vascular disease with a risk of gangrene and amputation. And you can assume that there is likely to be coronary artery disease and cerebrovascular disease too, increasing risk of a heart attack or a stroke. Feeling these pulses is difficult to begin with, but becomes easy with practice. Spend a moment to think about how many friends and family would let you examine their feet. Think about how often you sit on the sofa bored during the television, and worse when you could be feeling the pulses in your feet in your flat, mates, or your loved ones. Simulation has a role to play in getting you comfortable with a skill and getting over that embarrassing clumsy stage where you're not quite sure what to do next. It is not, however, real and the only way to get good in real situations is by practicing in real situations. So when you are competent enough and safe in your clinical skill, go and practice with patients. Examining patients is the main way that you will improve when practicing your clinical skills for the rest of your life. Asking patients for consent to help you learn. Most medical schools now introduce students to patients at an early stage, and a substantial, perhaps majority of your time studying medicine will be on clinical attachments with patients. We write more about this clinical learning environment. Later in this chapter, there is plenty written on the ethics of learning with patients and appropriate ways of approaching it, and the BMA does a particularly nice chapter on the subject which should be available in your library and in some institutions as an online textbook. You should have some teaching on how to approach patients and ask for their help in your learning fairly early on in your course. The key things to remember is that the patients need to know who you are and need to willingly give informed consent to help in your learning. The information that they need to enable them to give informed consent includes what will be involved, a true estimate of how long it will take, the fact that it is only for your education, and whether they say yes or no will not affect their care, and that you have the same duty of confidentiality as other professionals, namely that you will not discuss the patient outside of the clinical team or your learning group. You will be pleased to know that most patients will be eager to help you learn. If the patient prefers that you don't examine them, thank them very politely and then move on to the next patient. They might well feel up to it next time. Student, hello, my name is John Smith. I'm a third year medical student. Attached to your consultant, Dr. Jones. I'm currently learning how to examine the pulses in people's feet, and I was wondering if I might examine your feet. It will take no more than 2 minutes and will just involve me touching your feet to try and find where the pulses are. It shouldn't be painful or anything. It's just for my learning, so no problem if you say no. Obviously, never pressure a patient to allow you to examine them. Consent is a gift from the patient and should be given freely, and never allow the patient to misunderstand who you are. If they say yes, of course, doctor, for example. Correct them, oh no, I'm not a doctor yet. I'm a medical student. I'm just here to learn. Not only is this the right and ethical thing to do, but it also stops you from getting into trouble if a patient assumes that you are qualified. As a basic minimum, you must give your name and role. Explain what you would like to do. Explain that the interview is for your education only. Explain that refusal will not affect the patient's treatment in any way. Explain confidentiality issues, e.g., where will this information go? Who will see it? Say how long it is likely to take. Offer to come back later if the patient is tired, unwell, or expecting visitors. As a student, it is never acceptable to go ahead with an interview, physical examination, or procedure if the patient is uncomfortable. Equally, though, medical students have a right to learn, and many patients value the opportunity to talk to students and contribute to their education. Medical students are often viewed as neutral, that is, not part of the medical establishment yet, and some patients value the opportunity to talk, particularly as students may have more time than the other health professionals looking after them. Of course, this special relationship may result in a patient telling you something that they have not told the medical team, and so it is essential that when talking about confidentiality, you make it clear that you may share any information with the rest of the healthcare team. Feedback practice on its own is, of course, not good enough. Sportsmen have coaches for good reasons. It is hard to see what you are doing while you are doing it. There are lots of ways of getting feedback. Tutors are probably the most obvious candidates, an expert watching you and telling you what was good or bad. There are other ways of getting feedback too. You can ask a colleague to watch you and provide feedback. You can use video or audio taping to give yourself feedback, and you can ask the patient for feedback. As I said earlier, I'm a medical student and just learning. Can I ask how the questions I asked you about your chest pain compared with how the doctors asked about your chest pain? Did I leave anything out, etc.? Not only do you need to receive decent feedback, but you need to act on it too. You can find more information on giving and receiving feedback in Chapter 4. More and more medical schools are introducing portfolios and assessments that require evidence of reflection and action on feedback. You could think about adding a fourth page to each skill in your folder with two columns on feedback received and action taken. Not only will this help you to ensure that you respond to feedback, but it will also give you plenty of genuine examples for your portfolio and assessments. I practiced a lot at home on my little brother, but it was only in the retake course that I realized the importance of having other medical students giving me feedback. Hatharine, third year medical student, learning in the clinical learning environment. Transition from secondary school to higher education is a stressful transition, requiring changes to most aspects of your life. There is plenty of research to show that transition from the classroom in higher education to the clinical learning environment is equally, if not more, traumatic. Imagine turning up for your first full day on the wards. There is a timetable with a few sessions on a ward. Round here, a clinic there. There are lots of patients. There are few or no tutors visible. There are few, if any, objectives and little supervision. In fact, you could just go home and probably no one would notice. This section aims to give some tips on what to do, how to make the most of what is a pretty unstructured place. Approach to patients. We have already mentioned consent, but there are some other important issues to consider when learning with patients. Your school will discuss these with you, but as a brief introduction, you should be thinking about some of the following issues. Dress is controversial, but as a rule of thumb, you should be dressed smartly and modestly. In practice, this is likely to mean no trainers, jeans or caps, and not showing off your belly, however attractive your piercing is, your cleavage, or the top of your bottom. We shouldn't need to mention that you should be clean. Groomed, you should wear deodorant but not overpowering, perfume or aftershave, or too much makeup. You should be aware of infection control, especially how to avoid spreading infections between patients. This sounds easy, but take a look on the wards and count the number of people who don't wash their hands every time, who don't have their sleeves rolled up, or who break their tie or stethoscope. Over every consecutive patient, make sure that you are not one of them. Short, clean fingernails are essential for both men and women, regardless of fashion or guitar playing careers. Respect for patients can be demonstrated in a wide range of ways. You should consider your non-verbal communication. Looking uninterested, not paying attention, or chewing gum will not go down well. The language that you use should reflect your developing professional practice. So think about your use of slang terms and street language. You might even ask for feedback on this from your peers and tutors. Making the most of your tutors. We mentioned earlier on in the chapter that tutors were a good source of feedback, but the truth is that many students are observed very infrequently. Hospitals are bursting at the seams with people to teach you. The only problem is that they usually look busy, flustered, and important. One of our local professors was talking about teaching on the wards and said those students who just sit around looking bored, I try and avoid. them as much as possible. They just get in the way. But those students who are keen and enthusiastic, well, you'll do anything for them. I stay late. I miss dinner. There is nothing better than teaching someone who wants to learn. When I retire, I'll really miss them. One key skill on the wards, then learning how to engage your tutors, how to come across as enthusiastic, interested, passionate but not pushy. This is a skill you can learn by watching others and by a bit of trial and error, but here are some tips to start. You off don't sit in the corner of the ward looking bored. It doesn't engage others. Just wait for teaching to happen. You need to go and find it. Sneak off because nothing's happening if you really ever believe that. There is nothing happening in the hospital that you can learn from. You are in the wrong career. Yawn and open a book halfway through clinic. Assume that only doctors will be useful teachers. Nurses are generally better at many practical skills than doctors and have usually been taught how to teach. Pharmacists are highly skilled at taking medication histories and in spotting prescribing errors made by the doctors, the physios, the ward clerk. The list of people who you can learn from is huge. Assume that only the team that you are attached to are allowed to teach. You is a psychiatrist visiting your patient. Ask if you can tag along. Refuse teaching because it's time to go home. If someone offers to show you something interesting, go for it. Do look awake and attentive. Dress smartly, nothing extreme but smart and modest enough to show that you care about looking the part. Men should avoid stubble and make sure their shirts are ironed, and women should cover their navel and probably not show their underwear. Make the first move. I saw Mrs. Jones when she came in through casualty. Can I watch you do the lumbar puncture? Or I was reading about chest X-rays last night. Can you tell me what you are looking at on that one? Accept rejection. I'm far too busy to teach you right now. Should get A. Reply, oh, of course. I'm sorry. Is there anything I can do to help? Like take forms to X-ray or something. Ask for specific, achievable feedback. Asking, can you watch me while I examine Mrs. Patel is less likely to get an enthusiastic response than can. You watch me while I do a 5-minute cardiovascular examination on Mrs. Jones and let me know if you think I'm doing it right. Spot the learning opportunities. The last few paragraphs already try to highlight that hospitals are full of learning opportunities and that students who actively seek them out not only learn more but also get a reputation for being keen and enthusiastic and so get even more teaching. You can spend any dull moments trying to spot potential learning opportunities and then go out and seize them. The list is endless. We've put a few in table 3.2 to whet your appetite. Table 3.2 potential learning opportunities. Drug charts. Go around the ward looking at everyone's drug charts. Look up any drugs you don't know in the BNF. Ask for a blank drug chart. Put a thick line through each page so it cannot be used for a real patient in error and write something like medical student practice under the name. Now write up appropriate drugs for management of asthma or angina or heart failure and so on. Ask one of the doctors or the ward pharmacist to comment, cheer it up or take it home when done. Drug rounds. The nurses dispense drugs to patients several times a day. Why not? Offer to help. You might get to learn what that little heart-shaped pill that patients keep talking about is, and when you sit down to learn about the drugs, you will have heard of most of them before and even be able to pronounce them correctly. Practical skills. Patients get their blood pressure, pulse, and temperature taken between 2 and 4 times a day on a 20-bed ward. That's a lot of practice for you, and imagine how pleased the nurses or healthcare assistants will be for the help. Physiotherapy. Does your patient get wheeled to physio every day? What goes on behind those big swing doors. Why not go and find out? Radiology. Read about interpreting radiographs, let's say chest radiographs, and then go down to the radiography department and ask what day or time they report chest radiographs. Ask if you can come along and watch. The radiologists rarely have students, so you're likely to find one who is keen to teach. Have you ever seen a chest radiograph being taken? How about an abdominal radiograph or even an angiogram? What about ultrasounds? All these happen all the time in radiology departments. This list in table 3.2 is not even a start, but will hopefully get you thinking. We've concentrated here on wards and hospitals, but you could equally write lists of opportunities for general practice, operating theaters, outpatients, departments, and so forth. Summary. In this chapter, we have highlighted that learning clinical skills is important and takes deliberate, conscious effort. You will need knowledge about their skill, including how it relates to basic science and clinical reasoning. You will need to practice, practice, and practice again, and that practice needs to be reflective and linked to effective feedback in order for you to learn. Clinical skills are the fundamental skills of being a doctor. It is worth the investment. Questions and answers. Few tutors seem too busy to watch me perform a skill. A. This is a common problem. You don't always need a tutor to watch you, and a colleague might be useful to watch and give you feedback. There are some things that you can do to encourage your tutors. First, ensure that you have prepared your skill so that they don't feel that they are wasting their time teaching you things you could have looked up. And second, think about limiting the time that it will take. Can you watch me take a full history and examine this patient from head to toe? It will take about an hour, is not likely to result in success. But I've been practicing my cranial nerve examination. I wonder if you might watch a quick 5-minute cranial nerve exam and let me know if I'm doing it right. Sounds better. Hugh, every book and every tutor seems to have a different way of examining the breast. Which is the right way? The right way of examining a patient's breast is a method that will be thorough, systematic, will detect pathology, and will maintain the patient's dignity and comfort and your professionalism. Check with your medical school. For exams, they might expect you to perform a skill their way for the exams, but for real life and practice as a doctor, try different acceptable ways of performing skills and work out which is best for you. Hugh, not much seems to be going on, and no one checks that I'm attending on the wards. Wouldn't I be better off going home? Right? You can often get away with only turning up to the timetable things and slinking off home the rest of the time. But then again, if that is what you want to do, what is the point of you studying medicine?